Hi everybody, and welcome to our module on respiratory acid-base disorders. In the video on acid-base principles, I talk about the 4 types of acid-base disorders, and in this video we're going to focus on the first two, respiratory alkalosis and respiratory acidosis. The major features of a respiratory alkalosis are shown on the slide here. The pH will be elevated above the normal range, greater than 7.42, and the PCO2 will be low. These are the hallmarks of a respiratory alkalosis. And if you look at the Henderson-Hasselbalch equation at the bottom of the screen, what's going to happen in a respiratory alkalosis is the PCO2 will go down. That's the primary abnormality. Because CO2 is in the denominator of the Henderson-Hasselbalch equation, a decrease in PCO2 will lead to an increase in pH. That's why you get an alkalosis. And then finally, the bicarbonate level will fall as part of compensation. A respiratory alkalosis really only has one cause, and that's hyperventilation. Any patient who has a low level of carbon dioxide is overventilating the lungs and blowing off too much carbon dioxide. Now, there are many reasons patients can hyperventilate. Patients who are in pain may hyperventilate. Same is true of patients who are anxious. We'll talk in a little bit about high altitude exposure and aspirin overdose. Both of those can cause the CO2 level to fall. And then finally, patients who are on mechanical ventilation, if you set the ventilator to overventilate the patient, those patients can develop a respiratory alkalosis. And just by way of reminder, a normal respiratory rate is about 25 per minute. So patients who are breathing faster than that at rates like 30 and 40, these patients can develop respiratory alkalosis. Let's talk about how high altitude exposure can cause a respiratory alkalosis. So if you go to places on the globe where the altitude is high, the atmospheric pressure gets low. So for example, at sea level, the atmospheric pressure, as you may know, is 760. At the top of Machu Picchu in Peru, the atmospheric pressure is 560. Because the pressure is lower at high altitude, that leads to a lower partial pressure of oxygen. So for example, let's imagine that we have an alveoli in the lungs here, and blood is going past it to pick up oxygen. Partial pressure of oxygen in that alveoli at sea level is 100. But if you go up to the top of Machu Picchu, that level falls to 75. What this means is that even if your lungs work perfectly and you have no problems with gas exchange, the best PaO2 you can achieve in your arteries is 75 because you can't get higher than what is out there in the atmosphere. The primary problem, therefore, at high altitude is that patients develop hypoxia. They have low levels of PaO2 because of the low partial pressure of oxygen at high altitude, and this leads to a response of hyperventilation. And as I said before, hyperventilation always leads to low PCO2, and this leads to a respiratory alkalosis and a rise in the pH. And I've summarized on this table here some of the most important respiratory and acid-base parameters and how they change when a person ascends to high altitude. So the PO2 in the alveoli and the arteries decreases, as we said, the respiratory rate increases, carbon dioxide level falls, and the pH increases, causing an alkalosis. You know all the things in this table. You can answer lots of step 1 questions about whether or not certain parameters go up, down, or don't change with high altitude. Once you've been living at high altitude for a while, your body will begin to acclimate, and there are 2 important components to how the body acclimates to high altitude. The first one involves the kidneys. After about 1 or 2 days, the kidneys start to excrete bicarbonate. This is a response to the respiratory alkalosis. This causes the pH to fall back towards the normal range. And some people who climb mountains frequently, like mountain climbers, will take the drug acetazolamide to increase bicarbonate excretion. I talk about acetazolamide in the renal video on diuretics, but it is a carbonic anhydrase inhibitor, and it causes the kidneys to excrete bicarb, and this helps the pH to fall back to normal even more quickly than would normally occur. The second way that the body acclimates is through the red cells. Red cells begin to synthesize a substance called 2,3-bisphosphoglycerate, and this causes oxygen to be unloaded from hemoglobin, and I talk about this in detail in the pulmonary video on hemoglobin. Moving on, let's talk about what happens to patients who overdose on aspirin. Aspirin causes 2 acid-base disorders. Shortly after you take aspirin, patients develop a respiratory alkalosis. This is because salicylates, which are the type of drug that aspirin is, stimulate the medulla and directly cause the medulla to trigger hyperventilation. Several hours after taking too much aspirin, a different acid-base disorder happens. This is an anion gap metabolic acidosis, which I talk about in the video on metabolic acidoses. This occurs because salicylates can decrease the rate of lipolysis and uncouple oxidative phosphorylation. They can also inhibit the citric acid cycle. So through all of these metabolic effects, certain acids start to build up in the bloodstream, including pyruvate, lactate, and keto acids, and all of these cause an anion gap metabolic acidosis. So what does the arterial blood gas look like in a patient with an aspirin overdose? Well, first of all, the pH can be variable because it's a mixed disorder. Depending on the time course and the amount of aspirin that was taken, patients can be acidotic, alkalotic, or even have a normal pH if the respiratory alkalosis is balanced by the anion gap metabolic acidosis. The PCO2 is going to be low because these patients are hyperventilating, and the bicarbonate is going to be low because of the acidosis. What you need to always remember in order to recognize an aspirin overdose is that you have to use Winter's formula. Winter's formula I talk about in the video on acid-base principles. It predicts the carbon dioxide that you should have in the setting of a metabolic acidosis. In patients who have an aspirin overdose, because they have two disorders, Winter's formula will predict a CO2 that's higher than what the patient actually has. In other words, the CO2 may be lower than expected for normal compensation of a metabolic acidosis. This will make more sense if we just go through a sample case. So here's a patient with aspirin overdose. The pH is 7.36. This is below the normal range of 7.37 to 7.42. Therefore, this is an acidosis. The carbon dioxide level is 20. Normal is 40, so this is low. And the bicarbonate level is 11. Normal is 24. So when you have a low bicarbonate and a low CO2 and an acidosis, that is a metabolic acidosis. I talk about how to recognize this in the video on acid-base principles. Now, the mistake you don't want to make is to think that this is only a metabolic acidosis. It's actually two disorders. But in order to recognize that, you have to apply Winter's formula. So Winter's formula says that in a metabolic acidosis, the PCO2 should be equal to 1.5 times the bicarbonate plus 8 plus or minus 2. So if you put our numbers in here, bicarbonate is 11, you get that the PCO2 should be 25 plus or minus 2. Ours is lower than that at 20. This means that there must be a secondary disorder causing the CO2 level to be low, and the disorder that does that is a respiratory alkalosis. So this patient has a metabolic acidosis and a concomitant respiratory alkalosis. That is the classic profile of a patient with an aspirin overdose. So that's respiratory alkalosis. Now let's talk about respiratory acidosis. In a respiratory acidosis, the key features are a low pH below the normal range and an increase in the PCO2. Once again, looking at the Henderson-Hasselbalch equation in respiratory acidosis, the PCO2 rises. That's the primary abnormality. This causes the pH to fall, and then the bicarbonate level will rise in compensation. Just like respiratory alkalosis really only has one cause, respiratory acidosis also really only has one cause, and that's hypoventilation. There are many reasons why patients may hypoventilate. Some patients have a decreased respiratory drive from the central nervous system. Many drugs do this, like opiates and barbiturates. They decrease the respiratory drive and cause a respiratory acidosis. And then there are patients who have central nervous system disease, which can affect the respiratory center. Second group of patients are those who have problems with their respiratory muscles. So even though they want to breathe at a faster rate, they can't because they have neuromuscular weakness. Some of the classic disorders to cause this are Guillain-Barré syndrome, polio, multiple sclerosis, or amyotrophic lateral sclerosis. Patients with end-stage versions of these diseases can have a very low respiratory rate, which can lead to a respiratory acidosis. Some other causes of respiratory acidosis are shown on the slide. Patients with lung disease have impaired gas exchange, and this can cause the CO2 level to rise, and once the CO2 level rises, you're going to get a respiratory acidosis. So high CO2 levels are often seen in patients with pneumonia, pulmonary edema, ARDS, or COPD. And then finally, patients who have an obstructed airway obviously can't ventilate their lungs normally, so their CO2 level can rise, leading to a respiratory acidosis. So patients who have aspirated something or who have obstructive sleep apnea, in both of these cases, the lungs are not normally ventilated. The renal compensation for a chronic respiratory acidosis is to raise the serum bicarbonate level. It's super high yield to know this for step one. So what are the kidneys going to do when faced with a chronic respiratory acidosis, for example, in a patient with lung disease? Well, first of all, they are going to filter and secrete more hydrogen atoms into the urine. This is going to excrete acid from the body. Second thing they're going to do is reabsorb all the bicarbonate in the plasma, and then they're also going to generate more bicarbonate. What this means is that patients who chronically retain carbon dioxide, for example, patients with COPD, always have a high CO2 level in their bloodstream because they have lung disease. That chronically increased PCO2 level causes a chronic respiratory acidosis, and the compensation is an increased bicarbonate level. So patients who come to my clinic who have COPD, I don't often order an arterial blood gas to measure their CO2. But I do often check their bicarbonate because it's part of the standard chemistries that we assess. And the bicarbonate level is always high, and that's because it's the renal compensation for their chronic respiratory acidosis related to lung disease. And I'll finish with this slide and talk about acute hypercapnia. So hypercapnia can cause altered mental status by affecting the central nervous system. So patients who develop a respiratory illness and acutely raise their CO2 level can develop anxiety and headaches, and if it gets bad, they can become delirious or even go into a coma. So when a patient with lung disease who suddenly becomes confused or poorly responsive, one of the things you always want to think about is that they may be retaining carbon dioxide, and they may need to be placed on mechanical ventilation until whatever is causing their carbon dioxide level to be high has resolved. And these are the effects of acute hypercapnia. And that concludes our video on respiratory acid-base disorders.